Hey everyone, I'm Dean with Master Medics, and I'd like to welcome you to today's case. So we have a heavy airway focus this month, so I wanted to do a case kind of touching on that. So we'll basically just walk through the call together. You and your partner are working a double ALS truck in your town. You just finished up a neonatal disaster from a couple weeks ago, and thought to yourself, man, doesn't get much worse than that. And then suddenly your radio goes off. P4, can you clear the ED for a priority call? You curse the EMS gods and acknowledge. You're dispatched to the area of 101 City Street for the male party with facial swelling and difficulty breathing. On your way, you're thinking about anaphylaxis, you're thinking about all the other differentials for facial swelling and difficulty breathing, and a few minutes later you pull up to the street and park in front of the address. The patient meets you outside, and he's in obvious distress. Basically, he immediately pushes past you, gets into the back of your ambulance, and you recognize him immediately, and your heart kind of sinks. He's a regular, right? But not the like 30 calls a week for belly pain or the drunk guy on the street kind of regular. He's the kind where like everyone in the department knows who he is because he's sick 100% of the time he calls. The kind of regular where there's emails and like alert criteria and medical director emails about you've picked him up before, but never at this address, which kind of threw you off. So he's a 34-year-old guy, and his name is Tom. And he has something called hereditary angioedema. And then by the looks of things, he's not doing well. So, what is hereditary angioedema? So, hereditary angioedema, or HAE, is a rare autosomal disorder characterized by recurrent episodes of angioedema. It's caused by a deficiency or dysfunction in something called C1 inhibitor. So, without going too far into immunity, C1 inhibitor plays a really important role in regulating something called the complement system. And then it also regulates fibrolytic activity and then something called the kinin pathways. Basically, it turns off parts of this massive immune reaction set. The most important part for what we're going to kind of talk about with hereditary angioedema um, is that C1 inhibitor stops the production of bradykinin. So bradykinin plays a huge role in inflammation and inflammatory process. Basically, it causes the arterioles to dilate, and then it kind of makes the venules constrict. And what this ultimately does is leads to capillary leaking, um, and vasodilation in the capillary, stuff like that. And when you get this capillary leaking, you get edema formation, which is important in the immune response at baseline, right? Like when you poke your finger with a needle, it turns red, it gets hot, it swells. That's all bradykinin mediated. So when the white blood cells have or right white blood cells have done their thing, right? We want our immune system to turn that process off, right? We're doing all of that so we can like fight that infection or whatever's going on there. But then we want an end point. We also kind of want that whole thing to really only happen in the area we need it to and not all over the body, right? C1 inhibitor comes into play here, right? It stops that process. It turns off that leaking. With that in mind, what do you think happens when we don't have any C1 inhibitor or in some cases not enough C1 inhibitor? Basically, what happens if we don't have C1 inhibitor is we get bradykinin-mediated angioedema. We get these episodes of excessive bradykinin-mediated vascular permeability, and that leads to inappropriate edema formation. Now, this is different than angioedema caused by something like anaphylaxis. In anaphylaxis, you get angioedema, but it's a histamine-mediated angioedema. In hereditary angioedema, it's a bradykinin-mediated angioedema. So it has nothing to do with histamine, and it acts differently, right? You don't get hives, you don't get bronchospasm. These aren't problems in HAE. Um, these patients generally aren't hypotensive like your anaphylactic patients are. So how does all of this relate to airway? Well, unfortunately, it's one of those places where the patients get the angioedema. So, what is angioedema? Angioedema is the swelling of the deepest layers of the skin and underlying tissue, and it's caused by fluid accumulation down there. Unlike something like hives, which happen in the upper layers, so your urticaria, angioedema happens in the deeper part. You can kind of see that picture there. Uh, it also happens in the mucous membranes or the mucosa, which is what lines the inside of organs in different cavities, and it's also what lines the inside of your airway. We call these attacks of hereditary angioedema when they get these flare-ups of true angioedema, right? It's almost like an asthma, right? The patient always has asthma and then they get asthma attacks. It's the same concept here. The patient has hereditary angioedema. They have a C1 inhibitor problem, but then you can get attacks where they randomly can go into these kind of episodes. And there can be a whole bunch of different triggers for these episodes when it comes to stress, acute trauma, dental dental cases are a big cause of them. It could be like, the patient got into a fight with their loved one recently, and that stress caused them to go into an attack of hereditary angioedema. It could be a whole bunch of different things. So attacks of hereditary angioedema come in a few flavors. You get the laryngeal type, it isn't technically the larynx itself. It's called laryngeal edema, but we actually don't know if the larynx itself swells up or anything. Turns out they don't do a lot of like ENT cases when it comes to these because they're emergencies. Laryngeal just means upper airway. It's an upper airway related angioedema. Then there's gastrointestinal and cutaneous. And the patient can have any combination of each of those. Unfortunately, so abdominal pain's a big one, swelling's a big one, and airway emergencies can be a big one. And the patient can, again, have any combination of each one. And unfortunately, over half of all patients with HE or hereditary angioedema will experience a laryngeal attack at some point in their lives, which is like the big scary emergency for them. It's something they plan for, something they know about, something the doctor knows about, and it's something they can, sort of expect will happen. Um, it's also the number one cause of mortality in these patients, which is unfortunate. This disease pathway used to be a death sentence, and with modern therapy, and meds, and you know, good primary care and stuff like that, it's not anymore. They live to just short of an average lifespan, so mid 70s. But let's jump back into our case here. So Tom meets you at your ambulance, and he looks terrible. His face, lips, his tongue's a little swollen, and he's kind of panicking. He's had bad attacks in the past, and unfortunately, his hereditary angioedema favors the airway obstructing variety, so he oftentimes gets airway problems with his angioedema. But you've never seen him this bad. Fortunately, his friend was with him, and when you ask what happened, his friend kind of answers basically that Tom had a rough week. He's anxious, he's got a lot of emotional stress going on, which are well-known triggers for his attacks and his HAE in general. So he was over at the friend's house or his apartment in an effort to kind of feel better. They were just hanging out, and his friend knew something was wrong when Tom stopped drinking and kept rubbing his face and kind of pulling at his neck. So, Tom, his attacks happen pretty quickly, usually within an hour or so. However, normally Tom takes his rescue meds. So normally when you see him, he's calling 911 just to like go to the hospital to like, hang out, but he's taken his meds. He's already starting to feel better, or at least he's not actively as swollen as he is now. However, unfortunately for Tom, he accidentally left his meds behind tonight in a terrible turn of events. So Tom takes something called icatibant. It's a synthetic bradykinin beta 2 receptor antagonist. Basically, it's a fancy way of saying it blocks bradykinin from binding to its receptor. Essentially, it makes bradykinin not work anymore. Every other time you've seen Tom, he's already taken this rescue med, and right now it's not available. Beyond prescribed rescue meds, the only other kind of recognized treatment, there's three main rescue meds. You're usually prescribed one or two of those. But the only other really recognized emergency treatment for this is plasma, and your ambulance doesn't carry that either. But Tom is treated at the regional hospital pretty regularly, and they have specifically stocked his meds in the pharmacy, and it's only 40 minutes away. So you sit Tom on the stretcher and you start to move. Nothing else is going to work for him. So hereditary angioedema, the edema part of it, doesn't respond to epi or diphenhydramine or steroids or anything like that. Those all work on histamine. This isn't a histamine-mediated problem. It's bradykinin. Now, if you have an undifferentiated patient where you don't know if they have, hereditary angioedema and they look like anaphylactic and they're all swollen and whatever, you can try those things. It's not going to cause any harm. But they do not work for this condition. They will not make the patient better in any way. They're useless here. So Tom needs his rescue meds. So you put him on the monitor. He's got his heart rate's in the 130s, blood pressure is 134/80. Respirations are 30s-ish, and then his SpO2 is only 88% on room air. He's in obvious distress, and he's now only speaking, 4 to 5 word sentences. It's tough, but you can understand him. But you can tell he definitely has some cord swelling. So you throw him on some oxygen, you start a line, and a firefighter's driving, so you and your partner can both be in the back. And soon he's even more swollen. And even in just the 10 minutes you've been transporting him, you can tell he's getting a lot worse. He develops an obvious stridor, and he can really no longer talk all that clearly. His tongue is kind of, starting to protrude out of his mouth a little bit. It's getting obviously swollen. And you repeat his vitals. His heart rate's now in the 140s. His blood pressure is 130/80. It's not really changed. Respiratory rate's starting to come down, and ominously so. And his SpO2 is only 81% now, and that's on and on rebreather. So we're kind of in a forced hand scenario here. We need to get an airway, and you know it. It's one of those thoughts of anticipated clinical course, right? Better do it now before it gets even worse. So you and your partner develop a plan. So if you're going to do this airway, what do you think would be the best course of action? All right, so all joking aside, this is a tough case and probably the most difficult airway you'll perform. I prefer a double setup in times like this. So I would do a VL or video laryngoscopy with a cric kit out, open and ready. And I have access to those tools. If you don't, then it's probably going to be a little more difficult for you. But basically, I would give it one shot, maybe two, and then we're going to go to cric. So you do your normal pre-oxygenation stuff, apneic oxygenation, etc., just as you always do. You're well prepared. You kind of set up well. Use a checklist. You give some ketamine followed by some rocuronium. Your service doesn't do awake intubations or DSI or any of the fancy stuff like that. You're straight RSI service. And he's out. So you make your attempt. Nothing. Can't see a thing. You pull out. You make another attempt. Can't see a thing. Nothing. You pull out. His stats are terrible. 80s, 75, 70. You start to attempt to bag, and nothing. You try repositioning, you try a BLS airway, nothing. You get no chest rise whatsoever. His sats are in the 60s now. You look over at the LMA that's kind of sitting next to you. You look back at Tom's mouth, and you realize that that is not going to work. So, if you were doing this airway, what do you think is the best course of action at this point? So, unfortunately, you've entered a cannot intubate, cannot oxygenate scenario. So, really, here, there's only one thing to do. And assuming you're trained and credentialed to perform it, you need to do a cricothyroidotomy. We're in a failed airway algorithm. So it's important to keep in mind that this is for failed airways where you cannot intubate and cannot oxygenate, not just because you can't intubate, right? If you can still BVM the patient, if you can still use BLS airways, if you can still place an LMA or whatever be the case, do that. If not, that's when you would do a cric or a surgical airway. It's kind of when everything else has failed. The goal of failed airway isn't intubation, it's oxygenation, right? The placement of a polyvinyl tube doesn't define success in airway management. The goal is to maintain end organ oxygen delivery. Basically, a failed intubation is an emergency, but if the patient can be oxygenated, you have time to deal with that emergency. Unfortunately, here with poor Tom, we don't have that option. He's no longer oxygenating, and you can't intubate him, so our hands forced. So there's two types of crics. We have needle and surgical. Which one do you think we should try in our case? So here we're going to want to do a surgical airway. Generally, these are what any adult patient should get, assuming you're credentialed and trained to do them. If you have any doubts about that, the next time you're on shift or in school or whatever, go ahead and try to BVM through a 16 gauge needle. Find a way to attach it, however you would normally do your needle cric. Try to bag through that. It is not easy. You might get some oxygenation there, but you are not going to ventilate the patient with it. We won't even get into quick trachs and other devices. Those aren't easy either and kind of beyond the scope of the talk. So this patient needs a surgical airway. But first, we need to consider contraindications just like any other procedure. So uh, which one do you think, we should try we're going to try a surgical airway in our case. Are there any absolute contraindications to a surgical cric here? Yeah, there actually are. Well, one specifically. The rest are kind of relative. The one true contraindication is young age. Generally speaking, kids under 8 years old cannot get a surgical cric. Sometimes 10, depends what book you read. The kids' airways are too small. Their cricothyroid space is tiny. It's not developed yet. They also have really like pliable mobile larynxes. They have underdeveloped cricoid cartilages. Your landmarks are going to be really, really hard to find. The big one is the little kids. You can't do surgical airways in little kids. Other relative contraindications kind of focus around whether or not the procedure will be effective or not, right? Think about it. If the obstruction is down here, putting a cric up here isn't going to work for you. Things like that. All right, so let's quickly go over some anatomy and physiology before we talk about the cric itself. Here's where we want to focus. So here is your cricothyroid membrane, which is where we need to place our tube. It sits between the thyroid cartilage up here and then the cricoid cartilage down here. It'd be nice to see if we could actually see it that easily, but it actually kind of looks like this. And there's a lot of stuff over it, like fat and muscle and other tissues. And importantly, there's a lot of blood vessels in that area. And then the thyroid actually sits right on top of the cricoid. It's kind of buried deep in there. So how do we practically find it? You need to feel for it. Now, traditionally, people are taught to kind of start up by the chin and work their way down to find the thyroid cartilage or their Adam's apple, basically, right? Which is the biggest prominence that you'll have in the neck. And then the cricothyroid membrane is kind of right underneath it. So here's mine, right underneath it, right? I don't like this way. Let me tell you why. So here you have this big ridge, right? Followed by a valley, right? That's the cricothyroid membrane. But also over here you have this big ridge, followed by a valley. The epiglottis sits inside of the larynx, which means that this spot here, right above it, is extraglottic. You're not in the airway here. And then this can actually be a big problem. And I've actually personally seen a cric tube be put here because of this, and because the team started at the chin and worked their way down. And then I've also seen it in cadaver labs where um, you have someone with a really short neck and you don't fully hyperextend their neck when you go to do the procedure, which is an important thing to do here. And they feel the hyoid bone, the thyroid cartilage, and they go between the two because they think that that's that cricothyroid membrane, and it isn't. I like to start at the sternal notch and actually work my way up, because now when you start at the sternal notch, the biggest prominence, the first big prominence you find is always going to be the thyroid. And if it's not for some reason, so like let's say you mess up and use the cricoid instead of the thyroid, right? You're still in the airway. You just did a cric, or you just did a trach instead of a cric. It's not ideal, no, but at least it's still an airway. So I like to start from the bottom, so I find the sternal notch and then work my way up. You can do something called a laryngeal handshake, so you'll feel their larynx. Start from the sternal notch, work your way up. You're gonna find your thyroid. You're gonna let your finger drop back down into the cricothyroid space, and remember to always hyperextend their neck. So we need some stuff first. They make a whole bunch of different commercial kits and stuff like that, but you don't really need those if you don't have them. But they do give you a lot of options if you like trach hooks or dilators and things like that. I personally like the scalpel finger bushi technique myself. It's just what I've practiced a whole bunch and what I teach. But whatever way you want and are comfortable with and have practice is perfectly fine. So if you are going to do it with just random equipment that you happen to have, what size ET tube do you need to fit in the cricothyroid space? So you're going to need a 6.0 ET tube. Sometimes you can get a 6.5 in there, but a 6.0 is going to fit almost every adult. Now, this summary here was shamelessly stolen from First 10 EM, and it's made by Scott Edenborough. So full credit to them. I just thought it was a really cool picture. But it was perfect for this video, and basically what you're going to do is you're going to find your cricothyroid space, right? Just like I previously described. You're going to take your scalpel and you're going to make approximately a 4-ish centimeter incision, and it's going to be a vertical incision. And from there, you're going to refeel your space, reconfirm. You're going to blunt dissect tissue away. You're going to confirm your cricothyroid membrane again, and you're going to now make your horizontal incision. What I like to do is kind of dive the scalpel down into the cricothyroid space, make a cut, spin my blade, keep it in the space, make a cut the other way, pull the blade out, and then I'll shove my finger in. The shoving the finger in does a couple things for you. One, I can feel the back of the cric, so I can feel the back of the cricoid ring. So I can digitally confirm and tactilely confirm that I'm in the airway. It also, my finger kind of dilates the area I was just cutting, so it should make two passage a little easier. From there, I like to take a bougie and I will run it behind the back of my finger. So again, that tactile stimulus, right? I can feel it coming into the back of my finger, so you don't get like a false passage or things like that. And then you're gonna insert that until you get hold up. From there, you're going to take your 6.0 ET tube and you're going to put it over the bougie, slide it in, and then go just past the balloon. So you should just see the balloon disappear into the skin, and that's when you inflate it. Because keep in mind, you're further down than you would be coming through the mouth. So their carina is like a couple inches away. It's not very far. You don't want to rate main stem, so just go past the balloon. And then you're just going to secure it however your agency has you secure, whether that be a commercial device, whether that be some like IV tubing or shoelace or tape or whatever you happen to do. Just keep in mind there's going to be a lot of blood in that area, and that's a normal occurrence. And then also keep in mind you're not going to be able to see once this is cuts made. You can go on YouTube and like look up different crikes and the procedure over and over again and see what I mean. But you're not going to be able to see. There's going to be blood spurting and stuff like that, and it's a very tactile procedure. All right, cool. So jumping back into the case, you've successfully placed a cric. All of his vitals were improved, and the emergency is over. You secure it well, and you continue on to the hospital. Well done. So you arrive at the hospital and turn the patient over to the ED team, and the patient ends up getting his meds that were in stock for him in the pharmacy. And he gets admitted to the ICU for a few days. Ultimately, the angioedema goes away. Usually, once they get their meds, it'll go away within a few hours. Maybe not completely, but at least the emergency part will be over. Anyway, and the crate comes out, and the patient gets discharged home. Technically, hereditary angioedema will go away on its own. It's a self-limiting problem. It's just when there's an airway emergency, you have to have rescue meds to stop that emergency. Um, but it does go away generally in like 12 to 24 hours, if the patient can survive that long. But this is why these patients get meds. So his edema goes away, the correct comes out, and he gets discharged home a few days later. And then hopefully he'll never forget his meds again. That's all for today's case. Thanks for checking it out. If you're interested in more about Crikes, let me know in the comments below. Maybe I can try to like film one from start to finish or something when I'm at work and have all the mannequins and equipment and whatnot. But until then,